wonderful introduction. Thank you for that. Good evening, everyone. So I think Shri Priya has introduced me so well, and that's more than enough. And today we are in this session that is pain. We are going to speak about pain and its impact. I want each one of you to, switch on your videos, be very interactive because this session is going to be more of a case-based scenario where I want answers from all of you. I want you to post it in the chat box, or else if you want to unmute and ask any questions in between, you can raise your hand and then we can ask you to unmute yourself, and you can always feel free to ask your questions. So, are you ready? Looking at the chat box. I'll be continuously looking at the chat box. I want you all to respond in the chat box and be very interactive. Otherwise, it becomes a little boring. That's the only reason why I want the batch to be more interactive. And as I went through the participant summary of this batch, I was able to see that it's a much dynamic batch where we have doctors, MBBS, BDS, doctors from Ayush, the psychologists are there, the volunteers are there, the counselors are there. So I think you people have a lot of knowledge about this. You already have a lot of knowledge. We will look into further aspects on improving it. So shall we move into the session? Yeah. So what is pain? So what are your thoughts about pain? So there is one, excuse me. If it can be a bit louder, it will help. Other participants, can you hear me clearly?
Yes, we can hear you.
Yeah. Okay.
Ma'am, can it be make little bit louder? Volume is not up to the mark.
Okay. So we'll check on that. Just a moment. Maybe. Is it okay now? Yes, it is.
Maybe we will just move on, and if case someone is again facing this same issue, we will definitely address that.
Yeah. So have you experienced pain in your life? And if so, what is that pain which impacted your life the most? I want you all to comment in the chat box, whatever comes to your mind randomly, something you might get in your mind, right? Have you experienced pain? And what is that pain which impacted your life the most? I want you all to comment. And I'm looking at the chat box. Arthritic pain, okay. Dental pain, yes. Neuropathic pain, very good. Dr. Uma, I don't know if she's a doctor, but she says low back pain, yes. When it hurts because of appendix, yes, the worst thing. And what else? Ulcerative pain. I recently broke my humerus and that pain was very intense, yes. Labor pain, yes, definitely. Then, after cesarean, so yes, there are like multiple comments coming in the chat box. I'm so happy for that. Yes, definitely everybody would have experienced it. So have you ever seen that? Next slide, please. So pain has got different ways of expressions. Do you agree with that? So somebody mentioned labor pain, right? So how did you feel when you were in labor pain? When you were a mom? So when you went into labor pain, you had intense pain, but the moment you saw your baby's face, everything vanished, right? So yes, pain has different ways of expressions. And children, do you think children are sensitive to pain? Do they experience pain a lot? Yes, definitely. Children are very, very sensitive to pain, and even animals. So everybody experiences pain in a different way, and it has got different ways of expressions. For example, even me, if I come in the morning for work and then all of a sudden, I get a terrible headache and my pain score increases from 1 to 3, and by the mid of the day it might be very severe where my pain score would be 8 by 10, and then all of a sudden if my head or someone comes and scolds me for doing something wrong, how would I feel at that moment? My pain score increases, definitely, right? Because the emotional component of my pain also adds in, and I start crying. Sometimes people might get irritated, agitated. So yes, definitely pain has different ways of expressions. Next slide. So pain is a subjective experience. Do you all agree on that? Definitely, yes. Pain is a subjective experience. It is perceived by that particular person. And the International Association for the Study of Pain says that it is an unpleasant sensory and emotional experience. It is something which has a sensory component as well as has an emotional component, which is associated with or resembling that associated with actual or potential tissue damage. So that is the actual definition of pain. So we all agree now that pain is a sensory and an unpleasant emotional experience. And Robert Twycross, the person who wrote the book Introducing Palliative Care, so he says pain is what the patient says hurts. It's a very simple definition, right? Do you all agree with that? Pain is what the patient says hurts. So it is very simple definition for pain, and it actually defines pain in a much easier way. Next slide. So what is health? I think you all would have heard about this, that health is a state of complete physical, mental, and social well being, right? You all would have heard this definition in your life mostly, and it is not merely the absence of disease or infirmity. And what's the reason why I've put this slide in between? That is because today we will be dealing more about total pain. So, what are your thoughts about total pain? Here in health aspect, we say health is a state of complete physical, mental, and social well-being. And what is total pain? Can you put in the chat box? What are your thoughts about total pain? Physical plus the subjective aspects. Yes. So, what are those aspects? Pain plus circumstances of pain. Okay. What else? Score of pain, yes. Mentally and physically, yes. Very good. Pain is something that is physical and emotional. Indra says that. Such as social, finance, thinking of kids, spiritual aspects, psychological, emotional. Wonderful, wonderful, wonderful. So that is what I'm going to be talking about. So next slide. So here, before that, I want you all to read this case scenario, because this session is entirely going to be a practical approach where I'll be, sharing a case scenario, and at the end of the discussion, we will be asking you to put your comments in the chat box, and I really know that you all will come up with wonderful answers. So this is a case scenario. You can take a picture of it. If you're on your phone, you can screenshot it, or if you're on your laptop, you can take a picture of it in your phone. So this is the case scenario where Mr. Ramesh is a 45-year-old male who lives in a small village which is about 25 to 30 kilometers from your city. Okay, that has a primary health center. He worked as a carpenter, and he was a only breadwinner and was a chronic smoker and alcoholic. So, this had previously caused a lot of conflict in his house. He has two children, elder daughter who is 15 years old and younger daughter who is 10 years old. And 8 months earlier, this Ramesh was diagnosed with the squamous cell carcinoma of his left cheek. So he has an oral carcinoma which is there in the left cheek, and the poor financial status prevented him from undergoing treatment. Okay, so can you imagine this person right now? Yeah. So poor financial status prevented him from undergoing treatment, and now he has a large, irregular, and foul-smelling ulcer on his left cheek with a orocutaneous fistula. So what is it? Is because of the cancer, now he has got a big ulcer over here in the left cheek, and from there he has a fistula. A fistula is a communication with the outside. So what happens? Whatever he has, the food and water, whatever he has, it's going to come out of this opening. So can you imagine how distressing it will be for this patient Ramesh? So now he is in severe pain, and he is unable to sleep, eat, or drink. And his wife is refusing to care for him, and relatives do not visit him. Okay, so now the doctor from this nearby PHC has provided tap tramadol. So tap tramadol is an opioid which is given for pain relief. It is a weak opioid which is usually given for moderate pain. So I just want you to know the little bit of basics here. So this doctor who was there at the nearby primary health center has provided this medication for 2 days for pain, but there is inadequate pain relief. And this particular PHC, which is near to his house, does not have access to tab morphine. So tabmorphine is a strong opioid which is given for severe pain. In the scenario, I have told that this patient has a severe pain. Now, this patient has been treated for only moderate pain with tramadol. Okay, so that hospital does not have access to tabmorphine, and the dressing of this wound. Just imagine here there's a big ulcer with an orocutaneous fistula. All the secretions would be there. The muscle, tendon, everything is exposed. The nerves are affected, and definitely this needs addressing, right? So this dressing of the wound is done only when Mr. Ramesh can travel by bus to that tertiary hospital, and only when his wife agrees to accompany him. Can you imagine this entire scenario very well? Do you have any doubts on that? Please keep this scenario in your mind as we move through this session, and in the end we will have a discussion on this scenario. Clear? Have you taken a picture of that for your reference? Have you all taken a picture of that? Can you put it in the chat box? Yes. Okay. So very good. We'll move. Next slide. So the concept of total pain was introduced by Dame Cicely Saunders. So this person, Dame Cicely, was the one who introduced this concept of total pain. See what how interesting it is, because she was an English nurse initially. Okay, then she worked as a social officer, and then after learning a lot about palliative care, she turned into a physician. So she was the one who introduced this concept of total pain, and she was the one who founded the St. Christopher's Hospice in UK in the year 1967. So this nurse come doctor and social worker has given a wonderful concept that is on total pain. Moving into that concept, next slide. So, in palliative care, generally, pain is not just physical, not only in palliative care. Whenever you're going to see patients and families hereafter, when you go out, this concept has to be there in your mind very strongly. And whenever you see a patient and a family in serious health related suffering, understand that pain is not just physical. It has a physical component, it has a psychological and emotional component, a social component, and a spiritual component. So, how do we assess that? So, generally, pain is not just a physical experience, and it creates an emotional response. We were talking about it in the beginning of the session, right? Even when you are in labor pain, when you have a headache, definitely, though you have a physical aspect to it, you always have an emotional aspect to it. It also adds to a social impact and has a spiritual meaning. And all these dimensions, that is the physical, the emotional, the social, and the spiritual, will have either a positive or negative impact on pain, and it always alters the pain perception. So you need to always remember that pain causes more pain, and all pains are real. When I talk about emotional pain, that is also a real pain. When we talk about physical pain, that is also a real pain. So don't think that physical pain is only the real thing and the emotional, social, spiritual aspects are not real. Every aspect of total pain is considered as a real pain. You're with me? Yeah. So, what do you mean by pain has a spiritual meaning? That's a question there. So, I'm coming to it. I'm going to be explaining that in the next slide. Next slide, please. So, we have the explanation of total pain concept. This was given by Dame Cicely. So, in physical pain, a person might have many other symptoms. He might have insomnia. He might have undesirable effects of treatment. Just think about a patient with cancer. He might have went into numerous chemotherapy sessions, radiotherapy. All this is going to add a lot of difficulty. He or she might have xerostomia. He or she might have a dry mouth and nausea, vomiting because of the chemotherapy, which is the most common side effect after chemotherapy, right? So there are undesirable effects of treatment, especially in cancer patients, and insomnia and chronic fatigue. Because of pain, they might land up in sleeplessness, and they might have chronic fatigue, they might go into cachexia, anorexia. All these things are going to be the physical aspects. When we go into the psychological aspects, think about a person with cancer. most of these patients, especially for example, if you take cancer pancreas, most of the cases, most of these patients are diagnosed at the end stage. That is because it is very difficult to diagnose it in an early stage. And when they come to us, it is usually stage 3 or stage 4, sometimes even metastasis to some other organs. So definitely this person who has this cancer will have anger at the delays in diagnosis. He might have went and met so many doctors, so many, he went and met so many healthcare providers, went in for numerous investigations. So definitely there will be anger due to delay in diagnosis, anger at therapeutic failure, which is very, very high in a patient with cancer. Do you agree with me? Do you agree with me? Yes. So they might have went for numerous chemotherapy sessions, went for a surgery. Even a person with breast cancer will go for a modified radical mastectomy. Later, they might go in for a chemotherapy, radiation, and all these aspects will be there. And there might be therapeutic failure, which is very, very common in a patient with cancer because recurrence is very common. So anger at therapeutic failure is going to be there. Disfigurement. Just think about Ramesh right now. Put his image in your mind and just think about it. A person with a large ulcer in his left cheek standing in front of the mirror. How would he feel? That disfigurement will add on to the emotional distress and the fear of pain and death. Definitely some ulcer is growing, I'm getting affected, I have cancer. How am I going to deal with this? All these things will lead to fear of pain and fear of death and feeling of helplessness because they don't know what to do, right? And also the social aspect. When we move into the social aspect, think of Ramesh. He was the only breadwinner. Now he is, moving into, he couldn't go for a job, so the family will be getting affected, the children getting affected, is loss of job is going to be there, loss of social position, loss of role in the family, and feelings of abandonment and isolation, which will add to the social pain. And spiritual, when we say spiritual, it is not only about the religion that we are talking here, it is about how the person, as a person, how do we feel? Why has this happened to me? Have you ever had this question in your mind when some suffering occurs in your life? Even for your family or even for you, you would have always got this question in your mind. Why is this happening to me? I was so good. Then why God is, sometimes when a person is very, very religious, they would think, why God is making me suffer like this? But a person who is not religious would think, why this is happening to me? And what's the point of it? Why am I have to live like this? Or what is the meaning or purpose in my life? And I have done so many wrong things in the past. Will I be forgiven on that aspect? So all these things can come into your mind. So this is how we treat total pain. So whenever you are assessing a patient with pain, a patient and a family, always think that you have to go with the total pain concept. Clear? Are you all with me? Yeah. So yeah, Aparna says a bit like existential crisis. All are all physical symptoms of a disease considered to be physical pain in this context? Yes. So whatever is adding to the suffering, so whatever symptoms that are adding to the physical suffering, then that will be considered under physical pain. Clear? Yes. So moving into the next slide. So these are some of the factors which affect the pain perception. So it can be, the pain will be increased when the patient has feelings of anger, fear and anxiety, and boredom, when he is very depressed, he has any discomfort, if he or she is in grief, and other symptoms like vomiting, breathlessness, insomnia, and all these aspects, fatigue, all these will add to increased pain and lack of understanding about the disease. This is very, very common in an Indian scenario because here we always have collusion. Are you all aware of the word collusion? What is collusion? Can anyone, type it in the chat box, or even if you can raise your hand and answer, that's fine. Have you ever heard of this term collusion in your life? Yeah, Aparna, you can unmute and
Yeah, so it's usually the amount of information that the patient has about their diagnosis, whether the patient knows what the diagnosis is and the extent of it. Because many a times family members specifically instruct the doctors and nurses to not tell the patients about
Yeah.
the disease.
Yes, very, very good, very good. So that is collusion, which is very, very common in an Indian scenario. So as doctors or healthcare professionals, when we go and go for home care, or even when we sit in our OP, we have this relative, very close relative, the patient's wife or patient's son, daughter, anyone coming inside and telling us that, doctor, please don't disclose this to him or her because he or she might go into intense suffering. He or she might, break down a lot. Please don't tell it. So, what happens is when this particular person who is living with such a serious health related illness does not understand what has happened to him, obviously his pain gets increased. And there will be mental isolation and social abandonment when a person with an oral carcinoma, he cannot go out, he cannot go out because of that kind of an ulcer, so there can be a social abandonment happening. And even in India at these times still we have myths. When we go for home care, no, many a times the daughters, they will stand behind, and when we ask why are you standing behind, because they were told mother has breast carcinoma and it can spread to them, it is communicable. So such kind of myths still it is there in the Indian scenario especially. So all these factors will increase the pain. And when does it get decreased? When there is an acceptance. So when you break the bad news, initially it will be very difficult for any person to cope up, but eventually with time they will be able to accept it. So when there is acceptance, when there is reduction in the level of anxiety and some kind of relaxation, distraction techniques, all these things will actually decrease the pain when they start venting out their feelings. So it is very important. Now I think you will be able to understand how communication plays a major role in palliative care. So we should allow the patient and the family to sit and vent out their feelings when they get relief from all other symptoms. So they might have many physical symptoms like, like pain, as I said, like sleeplessness, nausea, vomiting. When you address everything individually and when there is relief from all of that, definitely pain also reduces. And when there is a good sound sleep and when you give explanation for why this is happening to you, definitely the pain gets decreased. And you always have to be there for the patient and the family till their end of life and even after their death. That is what palliative care talks about. It is not that only when a patient dies palliative care gets comes to an end. Not that. We always have to be there even after the death of their loved ones, where we give bereavement support to these families. So all these factors will decrease the pain perception. Clear? Shall we move? Yes. Yeah, Shalaka, you can speak.
Yeah, hi. I was wondering, if you're actually talking about suffering, because when you're talking about all of these symptoms and putting them under physical pain or whatever kind of pain, you're talking about suffering. Why do you not call it the management of suffering instead of pain management?
The thing is, we are dealing with total suffering and we are looking into the concept of total pain. And definitely here we are dealing with total suffering also. I do agree on that. But here, the concept of total pain determines that we have to look into all these aspects because generally we are not used to, treat pain in this way. So that is why this is something new which only palliative care professionals follow as of now. Only those who are trained in palliative care know the concept of total pain. So definitely we are going to deal with the total suffering. Invariably, we are actually dealing with the total suffering.
Yeah,
We have to address.
I thought this is total suffering in a way, right? I mean,
Yeah.
more than pain, it is total suffering.
Yes,
And the
definitely.
actual clinical aspect of pain,
Yeah.
it is, just a small aspect of it, which I understand. But I just thought the terms are very, not necessarily very definitively clear.
Okay. So yeah, definitely I do agree on that. But what I'm about to say is total pain is what we are dealing with, but definitely invariably we are going to deal with the total suffering of the patient in all aspects because it is a multidisciplinary approach that we follow. It is not that when a patient is in pain, only the doctor will sit, write the prescription and go back. Not that. A person like a psychologist, a person like a social officer, definitely we need their help also to support us in such
No, no, that's what
situations.
I'm agreeing with you. I'm saying what we are learning is actually total suffering.
Yeah.
And that's a better word for it, is all I'm saying.
Yeah. Okay. Next slide. Okay. So here we will be dealing with acute versus chronic pain. Just slide on acute versus chronic pain. So in acute pain, it is usually self-limiting and it is transient and its intensity reduces with healing. Just like, for example, you fell down and you had a scratch in your skin. It takes a little bit of time for it to heal, maybe a week or maybe 10 days, and then it goes off, right? So there it is called an acute pain, which is transient and self-limiting, and it is positive, right? When you fall down and you notice it, definitely it draws your attention and it is a protective factor. So acute pain is really positive and it is protective. Here we have other physiological things happening in our body, like pupillary dilatation, increased sweating, tachycardia, tachypnea, all these phenomena, the physiological aspects happening when there is an acute pain. Chronic pain is something which is persistent and it can be multifactorial with neurochemical changes which are happening in your brain. So, what happens is this chronic pain is negative because there is no useful purpose and it's a constant reminder of a life threatening disease. Say, for example, you had headache today and this headache didn't end up and it lasted for about 1 week, and now so many things would have come to your mind. So what's happening to me? The headache is chronic right now, it has not stopped. It's been 1 week, it's been 2 weeks, 3 weeks, your headache is still there. Every day you're getting headache or some kind of pain which is actually disturbing you, and it is a constant reminder of a life threatening disease. For example, me as a doctor would imagine, okay, let me take a CT and rule out whether I have a tumor, because we learn about so many things, and when such symptoms occur, we as a person, we start thinking a lot. So it is negative and it is of no useful purpose if your pain is chronic and lasts for more than 2 to 3 weeks, and it actually causes sleep disturbances. When you are in chronic pain, you will not be able to sleep well and there is no pleasure in life. You might get into depression. You have other changes happening in your body, like constipation can occur, personality change can occur. You will become very lethargic in your workspace. You will not be able to work properly. The quality of your life gets affected. So this is the difference between acute and chronic pain. Since acute pain is a positive thing which is happening to you, and chronic pain is something which is negative. So it is very important that we treat pain properly at the right time. Otherwise, what happens is, due to recruitment in the brain, we can end up with chronic pain. So just a slide on that, and then we will move further. So now we will move into the actual case scenario discussion. Okay. Before that, do you have any studies regarding the level of impact that chronic pain has on acute pain occurrence? Narmada, I need to look on that. I need to, Google and see if there are any studies regarding that. So this slide is specifically about clinical pain, not other symptoms of a disease, right? Yeah, today we are dealing only with pain and its impact. So impact in the sense how it is going to affect you as a whole and your family as a whole. That is why I have brought this concept of total pain here and this case scenario for discussion, so that it will be easy for you to, say, okay, these are the aspects we understand. So now moving into the case scenario, I think you all would have, taken a photo of it. Next slide. So I'm putting it once again here. If you want, you can read it, and then we will move into the discussion. I want you all to comment, because there might be multiple points coming to your mind regarding just read this scenario and then put your points on what are the aspects you think that can come under physical pain, what are the aspects that can come under the emotional and psychological, the spiritual and the social. I want you all to identify, and that's the reason why I've highlighted certain things in the case scenario, so that it is easy for you all to pick out and tell, okay, this might be coming under psychological, this might be coming under the social, this might be coming under the spiritual. Clear? So next. So ready to go? So you can just post it in the chat box. So just keep this in mind. So this person and this slide, and now I want you all to comment the aspects of physical pain in Mr. Ramesh. You can post it in the chat box, and then we will have a discussion on that. What are the aspects that can, yeah, the ulcer itself will give a lot of pain. Yes. What else? Pain while consuming foods. Yes, very good. I'm unable to sleep and there is too much pain. Yeah, sleeplessness comes under physical. Unable to eat, unable to sleep. Then it's very nice that you all are coming up with right points. Fatigue. Yes, very good. Anything else? Anybody would like to? So yes, cachexia, physical pain, shortness of breath, inability to maintain physical hygiene because of the pain and limitations from the ulcer. Yes. No one is even taking care. Nausea, vomiting, um, tension, not able to handle the disease. Okay. So yes, very good. So I'll just possibility of a liver disease due to alcohol. Yes, okay. So I'll just post whatever I had in mind when I was dealing with this case. So with the physical aspect, there is an ulcer. As everyone said, there is an ulcer. There is an orocutaneous fistula which has been for months. Chronic pain. Now this patient is in chronic pain because it's been for more than months, and definitely I told you in the beginning that that is a ulcer here, and the bone might be exposed, the nerves might be affected. So that is a concept for bone pain and neuropathic pain, definitely. And pain on chewing, swallowing and speaking, very difficult to articulate because he has an ulcer in the left cheek. Movement related pain, this is an area where we move a lot, we speak, right? There is movement of the jaw, so there will be movement related pain. And as you all commented, insomnia definitely is there. Nausea, that is because one reason is because he has an indurating ulcer with a foul smell there, that itself can contribute to the nausea. And also there was one medication that is started for him, that is tramadol, which actually has nausea, causes nausea and vomiting as a side effect. So that can also lead to physical pain. And hunger, thirst and dry mouth, just imagine he's not able to swallow anything, eat anything, though he is able to eat some food is going to come out like this. Imagine how it would be. So hunger will be there, thirst will be there, dry mouth will be there, the foul odor is going to be there, and the fatigue is going to be there. You're all with me, right? Yes. So these are the different aspects of physical pain in Ramesh. And this disease related physical pain is due to the malignant ulcer on the cheek and inadequate treatment of the cancer and inadequate pain management over several months. He is in severe pain. Until now, his pain has not been managed adequately. So now that has led to chronic pain. So whenever that is why I mentioned, whenever you see a patient with acute pain, please manage it properly. As doctors or even healthcare professionals, you should identify acute pain and manage it properly. Otherwise, what happens is it will lead to a chronic pain because of the neurochemical changes that are occurring in the brain. It is likely that there is involvement, as I said, is of the underlying bone and nerves with bone pain and neuropathic pain. And also we have muscles, right? So muscle spasm will also be there, which will worsen the severity of pain from malignancy. And difficulty in sleeping, insomnia and chronic pain have a reciprocal relationship with one symptom worsening the experience of the another. So this is based on a study. And Mr. Ramesh, sleep disturbance and chronic pain, both of them should be addressed concurrently. And next slide. Inability to eat and drink, hunger, thirst, and dry mouth will add to the physical suffering. And what happens is he is going to be in hunger for so long, not able to have food properly, and that will lead to weight loss, leading to anorexia and cachexia. And nausea and other side effects, as I said, can be due to the foul odor, can be due to tramadol, and leakage of saliva from the orocutaneous fistula. Just imagine the fistula here and the saliva coming out. It will lead to a lot of local discomfort as well as distress. And he is unable to get the proper regular dressings from nearby hospital. And there's a foul odor of the ulcer, which adds to the physical discomfort, right? So there's a foul odor coming up because the dressing is not being done properly. So in future, he might even end up with maggots in the wound because, when you're not managing the wound properly, if you're not giving wound care properly, then that will lead to a lot of, physical discomfort. And as someone said, withdrawal symptoms can also be seen in this patient Ramesh because he was on alcohol and tobacco for so long. So these are some of the physical aspects of pain that we will have to address in this patient Ramesh. Clear? Yes. So next is the emotional and psychological. So what might be the emotional and psychological aspects? Please comment in the chat box. In this person, okay, so yes, helplessness. He was a sole learner, so he'd be worried for the family. Yes, very good. Distress, frustration, anger. Yes. Wife is not supporting. Yes, definitely. Sadness. Isolated from his family because all his current relationships at home are hostile. Yes. Loneliness, definitely. Has no idea what is going to happen to him. Being a burden to the family, very good. Anxiety, very good, very good. Worried about children, yes, because he has two daughters, right? Helplessness, distress, nobody cares for him, regrets for the kind of life he had, yes. And feeling of guilt, yes, Darshana, very right. Due to history of alcohol and smoking, yeah. Aloof, yes. Previous conflicts will get magnified, yes, true, very true. Wonderful, wonderful comments. So, thank you so much for that. And moving into the psychological aspects, we have, yes, as you said, there is depression, anxiety, prior substance abuse is there, loneliness is there, guilt and shame because he was on alcohol and tobacco for so long, and he has an oral ulcer. So, he might think it might be because of the tobacco or tobacco chewing habit that he might have had, right? Fear of more pain, body image, and loss of sexual intimacy. Think about Ramesh. He's just 45 years old, and there is marital, conflict with his wife, and he is very young because of the ulcer and all of it. With the foul smell, there will be loss of sexual intimacy. They might have difficulties. So all these emotional and social aspects add on to the distress in this patient. He has a history of dependence on alcohol and tobacco, and always there is a co-occurrence of substance abuse and mental health disorders, which is well described in studies. And he may experience guilt as his tobacco habit might be implied as the cause of his malignancy. Relationship with his wife is strained, and she doesn't want to take care of him. Maybe because in previously he was not taking care of the family so well. He was, he was an alcoholic. He was a smoker. So all this would have affected his relationship, and now when he is in suffering, the wife doesn't want to take care of him, and he is shunned by relatives. Reason might be because he has a foul smelling ulcer and nobody is coming to visit him. And because of the disfigurement, the anorexia that has been set in, the foul odor that's there, it affects him psychologically, which will lead to a poor body image. When he sees himself in front of the mirror, he might feel emotionally down, right? So you all agree with me? So these are the important aspects of psychological pain in this patient, and his increasing isolation leading to depression, loneliness, and isolation generally have been described to be predictors of accelerated mortality. This is also based on a study, and now he is dependent on others for his care, hospital visits, and daily, needs. Now, even to go and do the dressing, he needs the support of his wife, and there is loss of independence and leads to poor self-worth. He is not able to do anything. He is not independent, not able to earn. All these things will be there, and fear and anticipation of greater suffering and impending death will also lead to anxiety. Yes. So moving into the next aspect, so what might be the social aspects in this scenario? What might be the cause? Lack of social support, yes, because there's no one to take care of him. Loss of confidence to face relatives, okay. Anything else? Social isolation, shame. Okay. Not having any support, loss of friends, even the ones who drank with him. Very good, very good. Yeah. No social life, fear of dying alone, loss of income, no mental, physical, and financial support from friends and relatives. Yes. So, yeah. So, all these things, whatever you have said, will affect the person feeling left out, lack of support. This will come under the emotional aspect too, feeling left out and the lack of support, emotion support, whatever it is. So, for the social aspect, yes, we have the financial status that is affected. There is loss of job, loss of role in the family. Now there is loss of independence. He's not able to now, get up, go and work, and marital conflict and isolation from friends and relatives, and health facility. Yes, Swati says health facility is 25 to 30 kilometers away. Yes, definitely. And poor support of healthcare and financial conditions. There's no one to take care of him and take him to the hospital. Even a volunteer is not there to take him to the hospital and do the dressing and all of that. So yes, these are some of the social factors. His social well-being is adversely impacted by his poor financial status and loss of job, and the marital discord as a result of his substance use also adds to his pain. And his disease and the malodorous wound led to isolation from relatives who are avoiding them, and even the friends, whom he considered as friends or drinking buddies. Now they don't even come to meet him when he is in suffering, and he also cannot step out of the house because of the foul smelling ulcer that's there. And he has lost his position in the society as an earning member, head of the household, and now feels dependent, poor, and isolated. And moving to the spiritual aspect, so what might be the spiritual suffering that this person might be undergoing? So this is how generally, when you might see many patients like this coming to you, but when you start, looking into all these aspects, you will be able to treat them totally. Whether you are a volunteer, whether you are a counselor, you are a social officer, you are a psychologist, a doctor, whoever may be, palliative care is where you have to apply your multi-centric approach. You have to go for a multi-centric approach. And yes, so here Indra Chowdhury says feels abandoned by God. Okay. Aparna says guilt because he was a smoker and alcoholic. Loss of previously held faith in God. Yes. Why God giving me so much suffering? If he was a religious person, definitely he will have this question in mind. And we don't know his religious status to determine spiritual suffering. An atheist is unlikely to ask the kind of questions you suggested. Yes, that is what I mentioned in the beginning. Spiritual doesn't mean only religious type of questions. It means a whole lot, like a person searching his meaning for in life. That itself is a spiritual aspect. It is not that we look into only the spiritual aspects, which is confined to the religious practices. Why me? And since we discussed caregivers yesterday, caregivers often experience clinical depression and can show suicidal ideation, which should be included in social pain. Yeah. Fruits of my karma. Swati says, fruits of my karma. And did I really deserve this? So, yes, so many wonderful answers coming up. Very good. So, moving into the spiritual aspect, we have why me? Life is unfair. Punishment for sins. I was, I was an alcoholic. I didn't take care of my family so well. And that is why I'm being punished right now. That might be one of the thought. And what is the purpose of my life or meaning in my life? Why should I, continue further in my life with so much of suffering? And also fear of the unknown. Is there more suffering after death? This question will be there in many patients' mind. Even we might think the fear of the unknown. We don't know what's going to happen after we pass away. So will there be more suffering even after death? Yeah, so that kind of questions will be there. And why do I live? Yeah, that Muhammad Suhail says, why do I live? So all these questions will come under spiritual aspects. He's facing his mortality. As you can see, it is a growing ulcer which is there with orocutaneous fistula, and it's getting into an advanced stage. So he's facing his mortality. He may question the unfairness of his life. Others who smoked and drank are healthy. while he suffers. And he might have unfulfilled dreams and the unmet needs to find purpose and meaning in life. So that is going to be there. And he has unresolved conflicts, even might be with his friends, with his family, relatives, with his wife, and may want to seek forgiveness from them, those he hurt because of his actions. All these things might be there in his mind, and we need to look into all these aspects. And he may see his disease as a punishment for past sins, and there will be fear of one unknown, wonder if there will be more suffering in store for him or if we will be relieved from it. His faith and belief systems will influence the spiritual suffering he experiences. That differs from person to person, and may also hold the key to provide him with relief from pain. So, as I said, spiritual aspect is something which is not only confined to the religious thing, but it looks into the person as a whole. So, spiritual pain might be different for different people. It depends on their practices, right? So, that is how it is going to be. Clear? So, yes, so moving into the next slide. So, as we move on, we should be very clear and we should look into the total suffering in every, as Shalaka was saying in the beginning. Here, you're talking about the total suffering. Yes, we have to look into the total suffering and we need to give total care for these patients. It is not that only we are looking at one aspect, that is a physical alone. So we need to relieve physical suffering by all means, by giving symptomatic management for all the symptoms, psychological support by giving emotional and psychological support for Ramesh as well as his wife. We might need to have a communication with his wife too, and we might need to sit and talk to them personally. And socially volunteer led things have to happen, and it can be facilitated to a nearby, the tertiary healthcare center where he can get a wound dressing. So all these things we have to look into. And for the spiritual aspect, many times when spiritual question comes, it is very difficult for us to answer. Basically, the person who's asking the question is not expecting an answer from our end. It is just that when such a question comes, if you are there for them, itself creates a lot of impact. So this is how pain impacts a person. The reason why I brought a case scenario for discussion is because I want you all to understand how pain can impact a person and their family as a whole. And that's the reason why the scenario was brought in, so that next slide. Okay. So the take home message has to be: the duty of every healthcare provider is to mitigate suffering. This was told by the Indian Council for Medical Research. The duty of every healthcare provider, not a doctor, not only a nurse, not only a doctor, but of every healthcare provider, is to mitigate suffering. Illness related suffering is much more than just physical distress. So we need to look into each and every aspect, as I said, the physical, the psychological, the socio economic, that's the social and the spiritual aspects, to treat a person as a whole. Okay, so with that, I finish off the presentation for today, and then we can move to the case presentation. I think you have one case presentation, and yeah, just a moment. Yes. Yeah, so there's one question, but what kind of spiritual support can be given to a person who is religious? Yes, you have to talk to them and, understand what is actually happening to them. What does he actually need? Does he want any, if he is a devout Christian, then if he wants to meet, go to the church or meet someone in the church, whatever he asks, we will be able to do. Whatever we would be able to do, we should be there and do that. And sometimes even, we have the priests coming to the inpatient unit whenever a person is dying, so that they would have told, like, we want this person coming up when I'm having such a difficulty, or when I'm in end of life, I want this person to come and sit near me and pray. So whatever they are wishing for, whichever we can offer, I think we should be able to do that as a team. Please tell us about what you did to mitigate these different kinds of pain for this patient. Yes. So, for example, so for the physical aspect, as we see, this patient had sleeplessness, this patient had pain. So, actually, he had to be started on a strong opioid like morphine. So, tramadol was given only as BD dosing, that is in the morning as well as in the night. And the minimum dose of tramadol that is to be started in a day is 150 milligrams. And it is based on the numerical pain rating scale. So we have this numerical pain rating scale, which is from 0 to 10. 0 stands for no pain. If the patient scores, see, when we take a numerical pain rating scale, it is a subjective pain rating scale. We ask the patient what is their pain score. We don't determine their pain score, but we ask the patient what is their pain score, and based on that we treat the patient. So that's why I said it is very, very important that we need to believe the patient. Sometimes you might be sitting in front of a patient who might be very charming, might be smiling also, but he might have a chronic pain, and you might feel like he is saying a pain score of 8 out of 10, which comes under severe pain, but actually he seems to be very happy or sitting in front of me with a smiling face. It is not that every person have to, physically look very much distressed. It is you who needs to understand that this patient is in suffering, and don't be judgmental while you are assessing and treating pain. Never be judgmental, and never assume. When a patient says that he has a pain score of 8 on 10, agree that it is 8 on 10 and treat his total pain. So maybe for this patient, he or she should have been started on tab morphine, which the minimum dose would be somewhere around 5 milligrams every 4th hourly, which is the oral morphine equivalent coming to about 30 milligrams per day. So that can be done, that should be done actually. And for the dressing of the wound, because he has a oral like ulcer which is there, so regularly we advise dressing twice daily, in the morning as well as in the evening. And we need to close the wound and keep it, because when you open it and keep, infections are going to occur, and then even the maggots can grow, and it lead to even more pain. And the bones are involved, the nerves getting involved, the neuropathic pain is being there. So it is very important that you address neuropathic pain in such patients. The patient might have a continuous nociceptive pain which is there, and also he might have a neuropathic pain. So for the neuropathic pain, we have different medications like amitriptyline, pregabalin, and several other tricyclic antidepressants which we have to start with. So one thing is addressing pain, and for the dry mouth, you can go with something like, pilocarpine drops, a simple thing like, a lemon juice, a few drops of lemon mixed with water, and then, just asking them to sip on that if there is dry mouth. And also ice cubes, pineapple chunks, all these things will be easy for them to just, just lick on that, so that it's the dry mouth and the dryness in this goes off. And Vaseline petroleum jelly, the white petroleum jelly also can be applied. That is one thing. And for the insomnia or sleeplessness that he has, you can start him on any sedative, a minimal benzodiazepine for the sleeplessness that can be done. So these are the different aspects that we have to look into in a physical pain. The chronic fatigue, the anorexia that has been set in, that I think we cannot, completely reverse it and make him look like a person who he was before. But then you need to make him understand that it is a component of the disease, and that's why you are getting the fatigue, the anorexia, and all of it. But definitely, when you manage all these symptoms, when you give symptomatic management for all the other symptoms, the nausea and vomiting, because he was started on tramadol, and as you can see in the prescription, there was no other drug which was given for nausea and vomiting. Whenever we start an opioid, we suggest that we start it along with a antiemetic like metoclopramide. Initially, at least for 3 days, we give a trial of metoclopramide 10 milligrams thrice daily, so that the nausea and vomiting, which is a side effect of tramadol or morphine, will be controlled. And once the medicine, like after 3 days, once the medicine has set in, then it is easy for them. We can give it as SOS only when needed. We can give the tablet in hand and ask them to take it only when that's needed. So that is how we deal with the physical aspects. For the emotional and psychological, definitely we have to sit. We have to have a meeting with the family. Maybe if Ramesh wants to speak separately, definitely we have to sit with him and speak, understand his concerns, what is that he is expecting, and if he might have a lot of, as we all spoke, he might have a lot of emotional and psychological issues that's happening. So definitely we need to address on that with the social officer. And if there is a component of depression, definitely we might need a psychiatric consultation. A psychologist has to take over. Something like a PHQ 9 questionnaire can be used, and you can assess the depression, and based on that, if he or she needs, if Ramesh needs a psychiatric consultation and medications for that, definitely you should do that. And as I said, diversion techniques, if he is in your hospital, definitely you will look into other diversion techniques, like if he is interested in music, if he wants to go and sit out for some time, go to a beach or something. Definitely as a team, you should make sure that you keep him happy. And you have to talk to the wife. You need to sit and talk to the wife, make her understand that he is undergoing a terrible suffering where he needs her support, definitely. But if that's not happening, it's okay, but because she might also have had some past experiences which is not allowing her to be with him. So you need to address that too. And for the spiritual, as I said, we need to understand whether he what he is looking for. It is quite difficult to assess spiritual pain in common practice. It is very difficult to assess. That's why I said, whenever a person asks you a question like why me, it is not that he is expecting an answer from you, but when you keep silent, just be there for him and be silent, that itself makes a lot of impact. So this is how you generally manage all these aspects. So volunteers can be involved, social officers can be involved, the psychologist in your team can be involved. So it is generally a multi disciplinary approach or a multi-centric approach that you are going to follow to give a total care for this total patient with total pain and total suffering. And in this context, I would like to say it is not only about this person Ramesh, but we are dealing with Ramesh as well as his family. See, the children would have dropped their school because the person is the Ramesh is not going to go for work. So what will happen to the children's education? So something that the social officers might be able to find out some schemes in the government where that can be linked, and the scholarships or anything which the daughters might be able to utilize. Then that options you need to look into. So these are the different aspects to pain and its impact. I hope it's clear for all of you. Yeah, so in reality, Darshana asks, in reality today, at what stage of diagnosis and treatment does the palliative care team get involved? So yes, if you ask me about reality, I would say mostly at end of life, or when a person is dying, is in end of life, or when there is no curative treatment possible. Only then, even the healthcare professionals are referring them to palliative care. But palliative care should actually start at the time of diagnosis itself. Whenever a person is being, diagnosed with a serious health related illness, then at that point itself, curative and palliative should go hand in hand. So that the reality is this, but we want it to be this way. So yeah, there's one case presentation, I think. Uma Kulkarni, are you ready with the case presentation?
Yes.
Yes, please start.
So I just want to give a background that this is a person I know remotely. I know their family, and that's how I put this case. This is not a terminal illness, in the sense the pain is not part of the terminal illness per se. Um, not the pain is not because of the condition that is causing the terminal illness, something else. So I hope it is okay here. So I'll start the case. Patient is 88-year-old male. He's diagnosed with essential hypertension with left-sided stroke post CABG. CABG is he has undergone bypass surgery, and he has bilateral knee osteoarthritis. So this is the one which I have now focused on for the pain issues. He was a farmer and now he's at home. His medical history is something like this. He was diagnosed essential hypertension with left-sided stroke, and this hypertension had started 20 years back, and he's on treatment for that. 10 years later, that is 10 years from now, he had a myocardial infarction for which he went to the hospital, and he was taken to the hospital by his son, and he underwent angiography first, and then they decided on doing a CABG. So post CABG, his activities came down, But at the same time, he also started manifesting more pain because of the knee osteoarthritis, which was bilateral, and he was receiving conservative treatment for it. Conservative treatment in the sense that the pain was very severe. He used to take some medications like non-steroidal anti-inflammatory drugs, and it was supported by some uh, gels or Brugel or Brufen gel or diclofenac gel or sprays or one of these kinds, and application of hot or compresses on the knee joint. He felt okay then initially. So this is the slide on the insight. I have written what comes to my mind because I'm new in this way of diagnosing and analyzing things. So as per the patient, the insight on the diagnosis is that he is unable to walk around in the house without experiencing pain at this point of time. From the last, say, since about 5 to 6 months. Before that, the pain was not so much. About the prognosis, he feels that the prognosis of osteoarthritis is not good because the doctors have again and again told him that the knee joint is so badly affected that nothing much can improve in that. So whatever the joint space is all gone, and the menisci and the soft tissues are all degenerated. There are a lot of osteophytes in the knee joint, which cause pain all the time. The moment he moves his knee joint, he's getting pain. And all the conservative management that he's receiving now is really not helping because he can't apply the hot fomentation throughout the day. Medically, he is not fit for knee replacement because this involves a surgery, both the knees, and he requires a lot of, he requires to undergo anesthesia, general anesthesia, which is not a good thing for his cardiac condition because after CABG, his cardiac output is very low. It's around 25 to 30%. So anesthetist feels that it is a high risk for general anesthesia. Regarding the diagnosis, what does the family think of? Family has been observing him and that he has pain while walking all the time. Sometimes it is more, sometimes it is less. So there's a variation in the pain. And the family members also accept that this pain is because of this chronic condition called knee osteoarthritis. And since the doctors have clearly stated that nothing much can be done, he only has to endure it because you cannot make any changes in the pain, the seriousness of the pain or the severity of the pain. It is good that he endures them. Regarding palliative care, the patient rejects all kinds of treatment. He believes that nothing is working for him. He's almost giving up. Whereas the family members feel that at least some supportive treatment would help. It will help in tolerating the pain better. So this is the family tree, family overview. This is the patient. That's the person who we are talking about, 88-year-old. He lives with his wife, 82-year-old. He comes from a family where obviously his parents are no more. He had many siblings. It's a big family. Two of the siblings migrated to the US long back. And when they were young and they settled there, they married the Americans and they have a family there. Whereas the rest of the siblings are in India, of which only one brother who's living in the village is alive and all the sisters have passed away. So he was not very close with any of the brothers and sisters, but the wife was in connection with, in talking terms, and she used to communicate with them often. So this was the generation up. Coming to the children, the farmer, he's a farmer by occupation. He was a farmer by occupation. He had 5 children, of which the eldest one was a son, followed by 2 daughters, 1 more son, and then 1 more daughter. So in all, 3 daughters and 2 sons. He lived, the dotted line here indicates that he used to live with this family. That is the eldest son's family, who has his wife and 2 children, 15 years back. The house was in a village surrounded by his land, all agricultural land. And in Mangalore, it's more of the rubber plantations and rice and coconut plantations, and he has been all through his life working almost like a laborer along with the other people who come to help him. So he has been very active in his life in his village home, picking up the areca nut, cleaning it, and then selling it, and so on and so forth. This was okay till 15 years back, but 15 years back, the eldest son passed away in a road traffic accident. So this happened all of a sudden on the day of a function when all the family members were at home. He went to get something from another place and he passed away. Following this, the whole family stayed with them. This family continued to stay together for around a year. But by the time it was 1 year, the daughter-in-law and the mother-in-law could not get along well. And so the family shifted to the city to stay with the second son. The second son, actually, this is a dentist. So it's by mistake, I think I wanted to change the scenario. So she's a dentist. The daughter-in-law is a dentist, and the son is a pharmacist. So they both have a background of medicine. They have 2 children, and they are staying here. And they were staying only as a nuclear family, and all of a sudden, the parents shifted here. So now this is the family where they are staying. So for the last 15 years, the two have migrated to the city home. The 2 brothers also have these 3 sisters who are all settled and well settled in life. 2 of them are housewives and one is a Ayurveda doctor. So this Ayurveda doctor has a daughter who is also an Ayurveda doctor, and they have a lot of say when it comes to the management of the father's knee condition. And the family believes, although this family believes in allopathic medication and management in an allopathic manner, there's a lot of influence from the Ayurveda Ayurveda doctor who's a sister. And there's always a clash between how the condition should be managed. So the other 2 sisters are there, they're housewives. They are basically emotional support to the whole family. Yeah, I think this is all I have to say about this slide. So Mr. M is what I call him. He's 80-year-old and he's the eldest son of a farmer who takes care of the farms and therefore is a school dropout. He took care of the farming all life, and whatever property was there, the farms were there. He was the one who was going to take care of everything. And so he dropped out from school. He hardly studied from 3rd standard or 4th standard or so. But 2 of his brothers migrated to the US. They are in touch with them. The eldest son, I already mentioned about it, died in a traffic accident. And this event was actually a major problem in the family because the elder daughter-in-law, and the mother-in-law could not get along. And therefore, there was a decision to shift to this house in the city. Yeah, we can, next slide, please. Yeah, Mr. M and his wife came to stay with the second son who lives in the city. And Mrs. M always has a bitter relation with both the daughters-in-law. So there's a lot of family problem. Day in and day out, there is a problem not adjusting to each other. Mr. M always supports his wife. The 3 daughters and the mother-in-law have a strong bonding, and the 3 daughters always support their parents. The relation between the daughters and the daughter-in-law is always stressed. After finding it difficult to adjust in the city, Mr. M and his wife still continue to stay with the son because there's no other way. And most of these families believe that staying with a daughter in old age is not an acceptable social norm. You are always supposed to stay with the son and not with the daughter. And it's the son's responsibility to take care of the parents and not the daughter's responsibilities. So daughters do not and cannot take care of their parents by taking them to their houses. So I have tried to draw this and I could not get more circles. Probably the experts can help me in getting more circles over here. The relationship between the family members I am trying to show. The daughter-in-law, both the daughter-in-law who is staying here, that is this lady, and the daughters don't have a good relationship. It's always arguments, and the mother-in-law also does not get along. So also the father-in-law with the other daughter-in-law as well as this daughter-in-law. The son is good to all. He is in good terms with everyone, including the parents. They have hopes in the son, but somewhere when it comes to the daughters, there is a negative vibe there. And with the neighbors, whoever is there, whoever comes to to the house, relatives, neighbors, it's a son who is in good connection with everyone, and not the daughters, not even the mother-in-law. So this is how I think probably we can add more circles here. You could help me in this. Socioeconomic review, they live in an independent house in the city. The son and the daughter-in-law have enough savings for their son's education, and they can take good health care of their parents, and they are doing that. Both the son and the daughter-in-law, they earn well. And coming to Mr. M, he doesn't have any pension, but after selling all the land in the village, he has a good FD, and in case he needs, he is financially independent. But all the expenses are currently borne by the son with whom he is staying. So I don't see any financial problems. So I was just having a thought that when we discuss about pain, when we discuss about suffering and terminal illness, we bring in a lot of component of financial issues. So here I wanted to keep away the financial issues and look at other issues which can also affect, because the terminally ill usually suffer from financial problems, but that's not the only problem. Even people who have good income and good balance or financial support also suffer, is what I wanted to highlight or bring in here for discussion. Psychological overview is that Mr. M is a very dominating person, has been a dominating person all life. So is his wife. They did not want their son, the pharmacist, to marry the dentist, since she belonged to a different subcaste. And that's where it all began. Right from the beginning, they did not like this dentist daughter-in-law. He likes to do gardening because his background has always been in the farms. He likes to do gardening even in the city house. And he plants trees around the house, small plants and trees around the house, waters them, takes care of them. But since he has knee pain now, he's away from all these activities, and he's more or less inside the house now. He used to go to the nearby shops to buy local vegetables, but because of the pain, he's now confined to his house, and he's very upset about it. Psychological assessment, this is as per my understanding. He gets angry very quickly. He expresses frustration over shifting to city life. So just now we saw a slide where pain can manifest in different manner. And in him, I feel the pain always manifested in the form of anger on everybody and including his wife. So he did not like the food made by the daughter-in-law because he also had a reason for it. The subcaste is different, and therefore I don't like the taste and the way she prepares it. His anger was all well known to all the relatives. Everyone in the close relation and even distant relatives knew about his anger. But this anger now became more as his pain increased and he was more within the house limits. His pain also went on increasing, and the anger also went on increasing to such an extent that one day he threw his daughter-in-law's mobile out of the window in anger. This has further strained the relationship in the family. Mrs. M continues to speak to her daughters during the day when both the son and the daughter-in-law are out for work and she's all alone at home. And she complains about the knee pain. And the daughter, who is an Ayurveda doctor, she sends medicines through relatives home. The son and daughter-in-law always claim that they never tell us about their pain. We are always not included in the management of pain. The sisters who are remote controlling and trying to give all the pain management. The son has taken Mr. M to orthopedician, has also taken him to the pain clinic. In the orthopedic clinic, he was given several injections into the joint, apart from giving a regular dose of tramadol. He's also received patches of lignocaine, patches of other drugs which help in reducing the pain. He has been injected many drugs into the joint, like the steroids or even the plasma rich fibrin and so on and so forth, which are still investigational. And he has also been taken to a pain clinic where a specialist has injected a lot of drugs into the nerves which cause the pain in the knee. So this nerves, the injection into the nerves is supposed to destroy the nerves going to the knee, thereby reducing the pain, but this has not clearly helped it. Finally, they have gone for radio frequency ablation of the nerves. So this is something like a terminal, you just kill the nerves completely so that there is no pain. Despite all that, when the pain specialist feels that now there's no reason to have pain because all the nerves there have been ablated or destroyed, the Mr. M still has very severe grade of pain, which the pain specialist feels it's unbelievable. The daughters complain about the daughter-in-law all the time, and this adds to the fights in the house and the pain increases. So this is my analysis of the total pain. His physical pain is like this. Movements are painful. Every movement is painful. Going to the bathroom, taking bath, walking out to the house, to the TV room is also painful. So TV is now shifted to their room. He lives indoor. He's totally indoor for the last 3 years or so. For the last 3 months, he is almost room ridden. Like he's always in the room and he's in the bed most of the time. Just goes to the bathroom and comes back. He even cannot walk to the dining room for food. He eats food in the bed where the plate is given to him on the bed. So this is his physical pain. The psychological pain is that he refuses to use any crutches. He feels he should. The pain is there, but it is his destiny and he has to face it. I don't want to use any crutches to walk. He says, I don't want to use any knee straps. He loses temper over small things, scolds his daughter-in-law, is afraid of his son. So he behaves little better in the presence of his son, takes psychological support from daughters over phone. And the daughter sends medicine, which gives him more pain relief than anything else that has been done. Socioeconomically, I don't see much problem here because they are well supported by the son. He has the confidence of having a big amount in the bank after selling the village property. So he feels even if the son abandons him, he still has money to take care of his medical expenses. Spiritually, I'm not sure. He's a very religious person. He believes in tantrics, pujas, and in Mangalore, there's a belief about Bhuta. And if you have a stone close to your house, which belongs to the Bhuta, you're supposed to perform pujas every year. And so many things are there which I believe. And the son and daughter-in-law always support him in performing all the pujas and never oppose it. So spiritually, he has been supported whether through finances or through taking them to the tantrics. So discussion points are primary concern of the son and daughter-in-law is he has very severe pain. It has restricted his mobility and reducing the quality of life. But the pain manifests as anger, which no one has a control on. Mrs. M does not get affected by his anger, just accepts it as his nature, whereas the others respond by feeling bad. She thinks pain is not too severe. He complains more than what pain he has. And his own concern is that the son's family is not doing much for his pain. So this is my discussion point. We can take it further by asking questions on how this family can be helped.
Yeah, so thank you, Dr. Uma, for bringing in such a wonderful case for presentation. Actually, this is a case presentation of difficult pain, to be very true, because here they have done so many interventions, and even they have went in for a pain clinic, and everything has
Yes.
been done, but still managing pain is very challenging. We need to accept the reality that as pain physicians or even palliative care physicians, sometimes we cannot give 100% pain relief of total pain relief to each and every patient. So the reality needs to be accepted here, because One reason is he has a lot of emotional issues, the anger, the irritation. It's been around 15 years. He has come from a different place and now he is living in a city, which itself can lead to a lot of emotional pain, which has been chronic. And also the knee pain, the physical aspect, which has been for many years now, and which is restricting his mobility. He's not able to go back and do his farming. Sometimes he might even think, no, I can't even manage a gardening at my home, or even I cannot go out and buy vegetables. That itself is adding to a lot of suffering, lot of physical, emotional, and the social aspect coming in. And treating a difficult pain definitely is very challenging for every healthcare professional. Might be anyone in the team, might be a doctor, might be a nurse, might be a social officer, a psychologist. Whoever is involved goes into a lot of challenges and stress while dealing with such patients. And even in pallium, we find it very, very difficult when we manage such patients. So it should be a multi-centric approach. We can try whatever we have. And even here, this patient has went in for a pain clinic, where I think lignocaine might have been given, the platelet rich plasma type of injections,
Yes.
which is usually given for an osteoarthritis of the knee, which is stage 4. Usually we prefer going for, when in such cases, here the patient is 88-year-old and he cannot go in for a total knee replacement. So definitely something, a procedure like PRP, or even they can be procedures like where we inject lignocaine along with the steroid, or even plain lignocaine, to give a temporary amount of relief. And the communication part plays a major role here. You have to sit with the family, sit with Mr. M, and tell him that it's been chronic. We have tried all the all the means by which we can reduce your suffering, and we are expecting might be a 50% relief of your pain, and not that we are expecting 100% relief of your pain. So person who is having a 10 on 10 might have, in reality he or she might have a good pain relief of about 5 or 6 bar 10, but we are not expecting something like 0 bar 10 or 1 by 10. So as a team, we also need to understand the reality of it and accept that we have done everything, we have given everything, but still it becomes difficult at certain situations like this to manage a patient with difficult pain. So that is one thing. And I think this group is a dynamic group. As I said, psychologists, counselors, and volunteers, everyone, you are there. So I want you all to unmute. You can raise your hand, unmute, and you can comment your suggestions, and you can give your suggestions to Dr. Uma, so that it becomes a wholesome. And it was a very, very nice presentation by Dr. Uma. Usually
I'm
we
sorry,
take
I
up
had
such
missed the last
cases.
slide. Yeah,
Okay.
sorry. Sorry.
Okay, so we usually take up such cases for our foundation course in palliative medicine, where we have certain topics on difficult pain. We have a separate topic on difficult pain. So this person will definitely fit into such sessions, and it's a wonderful, wonderful case for presentation. And I want
I
others
just
to comment on the plan, Uma has posted the plan here, and anything else anyone would like to add on, please,
I had missed it on the slide, so I thought I just added it later.
Okay.
I just thought that a common relative who has a strong connection with both son, daughter-in-law on one side, and the sisters and the parents on the other side could help intervene and bring about the differences which are there in the family. And they could together discuss about the plan, because there's always a issue about whether we should give Ayurveda or allopathy. So
Yeah,
that itself is a beginning point of all the arguments. So that could be so that he receives a more holistic treatment. Although finance is not the issue at all here, it's important also to involve the first daughter-in-law who stays in the village, and try to make an arrangement such that once in a while the old couple can visit that place and get the feel of the village, because I feel that is what they always miss. So going there and staying there for a period of say 1 week or 10 days would bring about a very positive change. So this was what I thought. Yeah,
yes,
that's all
as
from
you,
my
yeah,
side.
yeah, rightly said. And Indra also says, I was wondering if a completely different approach could be taken and he be asked to create a window garden So he begins to feel a little useful when he can use his previous
Okay.
skills. Yes, yes,
Yeah.
that's really
That's
nice,
it.
Indra.
Mm.
And a change of environment definitely is needed. Yeah, in this patient, that is definitely needed. Yeah, so this is a case. So we were talking about pain and its impact, and Dr. Uma has brought in a wonderful case for presentation where you can see the different aspects. As I said, you can see the physical, you can see the psychological, the social, and the spiritual aspect here, and you can put in your, whatever interventions that can really help this person to come out of such a distress. Maybe even, 50% of what he is suffering right now. If you can reduce at least a 50% of what he is suffering right now, because it is a challenging scenario. So very, very good. And Mohammed Suhaid says volunteer support would help. Yeah, that would also help him. And we need to sit and talk with the family, because there's a lot of conflict in the family, the daughter-in-law, all these issues are going on continuously. So we need to sit and talk with Mr. and Mrs. M, and also with the daughter, the daughter-in-law, and everyone, to understand what is actually going on and how we can help them, so that the social officers can do. And if there is a component of, anxiety or depression which is being found, then definitely a psychologist can come into picture, and you can assess that and help on that for Mr. Yam. And family therapy definitely might be needed here, because it's a big family, as we can see, and we need to interact with each and every one of them who are involved in the care of this patient. So it takes a lot of time. It's really time consuming, but definitely if you do it in the right way, it's going to help this person, Mr. M, and his family a lot. I personally think that it might be because of the change in the environment which has been there, for around 15 years from what life he was living previously. Now he is entirely in a different scenario, and that has been, so much in his mind that he is not able to go back to that setup and do whatever he likes. That can be an added factor.
Can I ask a question? While building this case, I had a doubt. What are the other circles to be included in the COPE in this case?
Circles in the sense, I don't get you.
Did you mean the echo map?
Yeah, in the eco map.
Mhm.
So
So there
we
might
were
be
supposed to.
not all there are no general factors like as such.
Uh,
Now, if
uh,
there were any religious institutions like the temple or church which were included, then there would be, if the patient had been in connection with some primary health centers, those could be included. So there is no such
okay,
specific rule that these elements should be there.
okay,
Whatever
okay,
factors are affecting that particular patients and his family's day-to-day life and this palliative care aspect as such, they should be included.
okay, okay, okay. Thank you.
Thank you. Thank you.
I think we had a series of chat
Okay.
previously also regarding the provision of
Palliative
medicine,
care.
starting with
Yeah.
Shalaka asking about medicine.
Mm.
And maybe one question specifically was directed to you, Dr. Hashmath. Maybe we can take up that first.
Yeah. Does the palliative care team also pay for the primary conditions, medicines for a patient who can't afford them? So it depends on the palliative care team. So we have NGO organizations, we have governments who are offering palliative care, but then it depends, because ours, for example, is a donation-based organization, and we have social workers who actually do the baseline socioeconomic assessment of each and every patient who gets registered with us. And based on that, if they come under a below poverty line, or if they can't afford that particular medication, then definitely we will give it. For a person or a family who's going to come from above poverty line, APL category, then definitely we will give the prescription. So it depends on the organization where you are working in. And if, for example, nowadays, even primary healthcare centers, they issue medicines free of cost. So, for example, if a person is on an anti-diabetic drug like metformin, or even like, atorvastatin, or some antihypertensive drugs, we would suggest that this particular person and the family goes there to collect those medications, and only those which are not being provided by PHC, and for those whom this a person cannot afford, then we will be providing it. But we have an assessment for that. Our social workers will do a detailed assessment when such medicine needs come in, and after that assessment, the team makes a decision whether we have to provide it for such families. For every requirement, can be a wheelchair, can be anything, because we are a donation based organization, and before we given something, we need to be very careful with the proper allocation of our resources and how we distribute our resources.
Right.
That's
Just to add this, the medication part under the NHM, that is a National Health Mission, there is a project called Vyomitram. Under that, patients will get their medication if they are eligible, like whether they are under the BPL or according to their economic status, they will get the medicine free.
Thank you, Mr. Sudesh, for adding that.
Thank you so much, sir. That was
I
valuable information. If you could post that in the WhatsApp group as well, it would be beneficial.
Niharika?
Yeah, ma'am, this discussion, what was going on. So just I got a question from this only. So does Pallium India helps patient like who are not like who are on the other part of the country, or the patients who are only in Kerala?
No. Pallium India supports patients and families from other states with a helpline called telehealth. So we run a helpline which is operated from Monday to Saturday from morning 9 to evening 4:30, and we have a helpline number where patients and families with serious health related suffering can reach out to us. They can just call us via the helpline, and we actually get back to them. We have a forum where all these we get all these numbers whenever they call us. It's like a customer care. Whenever you call a customer care,
Okay.
you will be told, right? So there's an information coming up, and then once you can there will be a beep sound, and after that you can speak. You can say, I am so and so calling from this region and I need help. And after that, when we receive your call, we will call back. We have a telehealth team working on that. We have a social officer dedicated for telehealth, a doctor as well as a nurse. So the nurse will be calling you back, and she will do the initial assessment, and based on that, a video call or an audio call will be done from our end based on the need, and then we will prescribe medicines over telehealth, whichever is possible. We will do that. Or even if you want to get connected to a nearest palliative care center at your place, we will direct you there.
Just adding to that, Pallium India is maintaining a directory of all palliative care providers across the country in the
So
website.
that's one.
So I'm posting that link also in the website, in
Yeah.
your chat. If you, I think Niharika was saying something.
Niharika, you wanted to say something?
One more. Yeah. Thank you for the answer, ma'am. And I have one more question. Like, since
Your voice is breaking, Niharika, so we are not able to hear you.
mentioned that you help our patients. Am I audible now, ma'am? Am I audible now?
Yeah.
Okay. So my question is that you mentioned that you help patients who are like below poverty line. But
Still
there
losing.
are a few patients, I mean, I have come across.
So I mean to get your question, like I was saying, that a patient who comes under below poverty line
Few,
will be
so they're
getting medications.
they're not like, so is it possible to like
So with what I understood, I can answer this question by saying that even if a person comes under, based on the card, if they come under an above poverty line, and if our social officers feel that we need to support them by any means after their detailed psychosocial or the social assessment, definitely we will be able to provide that from our end.
Just adding to that, I think we can put it this way. Our end aim is to improve the quality of life of the patients who really need that.
Yeah.
Of the deserving ones. So it is not based only upon their financial status.
Yeah. So,
What are the criteria for free care?
Criteria for free care, I don't get it, Muhammad Suhail. Can you be a bit more clear? And I hope you found this session helpful. Thank you, Indra, for that thumbs up. It looks really nice. So yeah, thank you so much. And if you have more questions, you can always send that to Shri Priya, and then she'll be able to send it back to me, and I can reply you with the answers. I'm always available for that. Yeah, thank you so much. And it was a very, very interactive session. I really loved the participants' interaction in this session and the case scenario, especially by Dr. Ruma. It was really, really good, which brought up even more enriching discussion. Thank you so much, everyone, for
Thank you.
joining me today. And it was a great, great day for me. Thank you.
Thank you so much. Thank you.
Thank you,
Thank you,
Dr.
everyone.
Hashmath. Thank you, Dr. Hashmath. I know we are
Thank you.
sitting together at the office, and I know Dr. Hashmath has been held up the entire day just like me, and her day is going to end not even by not even by 8 p.m. just like me. So thank you. Still, you found out time to interact with this wonderful batch, and we had an enlightening and interactive session as promised. So, with the promise that we'll be meeting again in the next session with another important topic and yet another eminent speaker. This is Sri Priya along with Dr. Hashmath Farhaana signing off from the Tips Eco Hub. See you in the next session, everyone. Till then, take care. Bye bye.
Bye.